About sexuality and pregnancy. Now, there's a separate room. If men want to go to a separate room, there is a separate room that has male doctors there. And the topic is, in that room, it's directed towards the difficulties that men will have. In this room, we're going to discuss the difficulties in sexuality and the difficulties and successes in having children. So if I can have your silence, please. We're moving straight into that program because we're tight on time. We're going to begin the next session, and I want to introduce to you, we have two professors and some patients to give you their experiences here today. And some of them you'll know. I'm beginning with Professor Tincani. Professor Angela Tincani is from Italy, and she has done a lot of studies on this particular subject. She's the full professor and chair of rheumatology at the University of Brescia, and head of rheumatology and clinical immunology, also in Brescia. Please enjoy her presentation.
Thank you, Anne. Thank you for inviting me here. I congratulate you for the success of this patient meeting that is really full and very interesting. I am not sure to be the right person to present this topic to you. However, I will do it with enthusiasm. Scleroderma is a severe disease that affects vessels, that cause fibrosis and inflammation, and is a female disease. Always, but particularly when you go from 15 to 50 years of age. Little is known of the impact of scleroderma on female sexual functioning and on their quality of life in the sex area, but even less is known of what we can do to improve this issue in this kind of patients. What we know is that women with scleroderma have a high level of sexual impairment, even when you compare them with other patients with chronic disease like breast cancer and HIV infection, because in this different category of patients, this topic is much more discussed and not so much discussed in scleroderma patient. But what is the proportion of the problem? So how many patients have a good sexuality and how many patients are impaired? So according to this paper, around 40% of scleroderma patients are sexually active and around 60% are inactive. But if you go into the active part, you see that the majority of them have some impairment. And this, why? Why this happen? Well, this happen because many symptoms related to scleroderma, such as gastrointestinal symptoms that we heard in this audience this morning, like Raynaud phenomenon, like breathing problems of which you heard a few minutes ago, are able to impair sexual activity and are related to sexual inactivity. And most importantly, the pain in the vagina area are very give a most prominent differentiation between patient with normal sexuality and abnormal sexuality. But the phenomenon is not that easy, because if you look into the area that patient relate to their sexual problem, you see Raynaud phenomena, you see all the vaginal problems, but you also see depression. And in this particular work, it is said that only 70% of the patient interviewed said that the primary reason of their sexual inactivity was scleroderma. So, this come out in a better way when you compare sexual functioning with quality of life investigated by SF-36 scale. You can see, in fact, that quality of life is related to mental component, to general health, perception, vitality, social function, and so forth, and not to physical problem linked to scleroderma. So, why? There is a psychological component, a sort of depression, general depression, that is very much associated, probably more associated to sexual dysfunction than physical problem themselves. Why this happen? Well, scleroderma is a really difficult disease, and there are a number of things, like thickening of the skin of the face, of the elbow, problem at the fingertips, and so on, that lead the patient to have a body image dissatisfaction, particularly if they are young, and particularly if they are a severe disease. And body image dissatisfaction cause psychological problems and cause depression. This is even bigger in patients with scleroderma than in patients with severe burn injuries. So it's really a big problem, the body image dissatisfaction. Body image dissatisfaction is a significant concern in humans with scleroderma and should be assessed routinely, because if this problem is identified early, can be treated by psychological intervention, such as cognitive behavioral intervention, and this can be in some way managed. So we have a little bit analyzed why the person with the woman with scleroderma have a sexual problem or sexual inactivity. But now, what to do? Well, we start from the fact that this disease is a vascular disease. And at least in men, inhibitors of type 5 phosphodiesterase has been shown to be effective to care the erectile dysfunction that is now considered related to a vasculopathy. In animal model and in experimental model, the same class of drugs seems to help also female problems. But for human, the things does not appear so easy. In fact, as you can see here, as a sub-analysis or part of a study on the use of tadalafil in Raynaud phenomenon and on its effectiveness, it was also checked if this drug could help the female sexual functioning in patient, of course, with scleroderma. And this was a case control, a control study with placebo and with inversion of the groups, as you can see here. Well, unfortunately, no statistical difference were found between drug and placebo in the 6th domain of female sexual functioning. Although it was reported that a patient in the period that they were taking the drug, they could have more sexual intercourse. This could be due to many things, included the fact that probably in that trial the amount of drug was not that effective also for Raynaud phenomenon. However, according with this data, tadalafil seems to give a limited help, if any, to sexual function in women with systemic sclerosis. So, to achieve some improvements, what we can do? We can suggest simple health intervention, such as the use of vaginal lubricants, such as the use of extra blanket or the adjustment of the room temperature for avoiding Raynaud phenomena. We can advise about particular positioning that can avoid musculoskeletal and perineal discomfort. The sexual activity could be planned when the woman is not tired and when the woman has taken anti-inflammatory drugs that are still working. Maybe that a warm bath can also help. And we can give them general advice about a relaxation technique and energy conservation. Not all these things can be done by the rheumatologist or by the internal medicine doctor. She can also be advised to hear a psychologist, to hear a sexuologist, to hear other specialists. Of course, some drugs could also help, but studies are lacking at this moment. And we have not to forget that additional intervention, such as psychological intervention, is also necessary, because well-being is something that needs physical health, psychological health, and social health all together. Then, to achieve some improvements, we also need an optimal physician-patient relationship. And here I have listed mistakes that myself do every day and that need to be avoided. I am sure that all your doctors already avoid these mistakes, but just in case, I show them to you, just a sort of mea culpa for what regard myself. So, physician and also other care providers sometimes may avoid to speak to patient about sex and sexual problem because the topic is sensitive and they are afraid to cause embarrassment in the patient. Healthcare provider may also think, and sometimes I must say it could happen, it happened to me, that patient with a so severe disease, such are the patient with scleroderma, are not sexually interested or active, and this is a mistake. Another mistake is that all of us who do rheumatology or internal medicine maybe think, or some of us think, not to be properly trained to enter this sensitive area with the patients. Although we think it is important, but we think, look, I am not able, I don't try it. And sometimes we wait that people ask us some question, but on the other way around, the people is shy to speak and to ask about things that they want to know, and they want to be also reassured that these are problems not of one individual, but of many individuals, and should be somewhat faced and solved. So I thank you for your attention, and again I tell you that I was not the good person, as you have seen, to speak about this thing. Thank you.
Our next speaker is Professor Virginia Steen. She has a long-standing distinguished career working with scleroderma patients, beginning at the University of Pittsburgh in Pennsylvania, and including her current position as Professor of Medicine at Georgetown University in Washington, D.C.
Thank you. And thank you very much for the organizers for inviting me, and I'm very pleased to be here and talk about this topic. Before 1985, when I actually was starting in rheumatology, the sort of general understanding was that scleroderma patients should never get pregnant. They'd have bad outcomes. All the babies died. The mothers just got renal crisis, and there was no option for women with scleroderma. As a young doctor, I did see a few patients, and I was very fortunate to receive a grant to study this. And so I am going to share a lot of the work that I've done through the years with this. So the first question, as far as being safe, is what happens with the baby? We'll start there. And so this is the first study that we did. It was a retrospective study, so I gathered a large group of scleroderma patients, compared them to rheumatoid arthritis controls and neighborhood controls, asked the patients to give me a neighbor of theirs. And I think you can see that there really was no difference as far as miscarriage. In lupus, there's a very high frequency of miscarriages, but we did not see that in scleroderma. As far as premature babies, we did find both in scleroderma and in rheumatoid arthritis, questionable just the fact that they had a chronic disease or many medications. They did have an increase. There were also in scleroderma small full-term babies, questioning whether the vascular issues or medications or whatever, but importantly, there was not an increase frequency in neonatal deaths. So that was important for us, that at least we knew that there wasn't bad outcomes in the babies. We then went on to do a prospective study following 59 scleroderma women with 91 pregnancies over actually the next 10 years. And when we looked at these same outcomes, we looked at the time of the disease and the type of the disease. So we looked at early and late limited, early and late diffuse. And as you can see here, interestingly, as far as the miscarriages, although the overall group was similar to what the previous group, we did see in the late diffuse patients really a significant increase in having miscarriages. And several of those patients and issues were people that had significant lung disease, so that was of concern. As far as prematurity, there was also an overall increase, but as you see, the highest increase was in the early diffuse group of patients. Overall, full-term babies were similar, although the best outcomes were in early limited disease. There's been a more recent study, the Italian study, the IMPRESS study, which is, again, a retrospective study, and they, again, found no increase in miscarriage. They found the similar increase in prematurity and some increase in growth retardation, which is sort of the same term as I did, small full-term babies. And again, they found some differences, particularly in the diffuse scleroderma patients versus the limited scleroderma patients. There is an ongoing prospective study, again, done by the Italian group, ongoing. So now what happens to the mother and what happens to the scleroderma during the pregnancy? So when in our prospective study, we looked at, as far as overall scleroderma symptoms, there was most of the patients, the symptoms were the same. There were some in each group that had improvement of their symptoms as well as worsening of their symptoms. And so what I'm going to talk about here really is just what happens during pregnancy and the scleroderma symptoms. So as far as Raynaud's, Raynaud's is generally improved during pregnancy. The patients have increased blood flow, and they really always feel warm, and they like not having so much difficulty during pregnancy. There was an increased frequency of Raynaud's, particularly in the postpartum period as they change all their hormonal status. There were more joint problems, not inflammation, but just joint pain, and that actually was similar to other pregnancies. Pregnant women do have more joint pains in general. We did not see a major change in the skin thickening during pregnancy. There were some patients, and I've certainly seen myself, some patients after pregnancy that had worsening of their skin. And the biggest change were in people that were in early diffuse stage, so that they were having worse skin during the pregnancy because they were in their early disease stage. Many patients ask me about if they have very thick abdominal skin, whether that's okay, whether their skin will stretch, and it does. And we've not really felt that having very severe abdominal skin thickening interferes with the pregnancy at all. So gastrointestinal problems. Certainly pregnancy causes more reflux, and that's not surprising that scleroderma patients have more trouble with their reflux since they have it to start with. Malabsorption and bad overall GI outcomes did not happen in our patients. Lung involvement is a really important issue to talk about. We did have several patients that had significant interstitial lung disease with a low forced vital capacity, and we were able to get some healthy babies during those pregnancies, but we encouraged the mothers to use oxygen even if they didn't really think they needed it, but we wanted to optimize it during that time. As far as heart involvement, if heart involvement was present, you just treated it as any other heart disease, and it didn't seem like there was any specific problem during the pregnancy. Pulmonary arterial hypertension is an extremely high-risk manifestation to get pregnant, and it's really strongly discouraged for anyone with pulmonary arterial hypertension to become pregnant. One of the big controversies as far as whether renal crisis occurs during pregnancy, and in the retrospective studies that we did, we found 4 of our 23 patients that had, during pregnancy developed renal crisis, which was 17%. When we looked at all of our other scleroderma patients, our diffuse scleroderma patients, particularly during that same time period and during the same disease duration, we found that the actual frequency was 22%. So we really felt that when renal crisis did occur during pregnancy, it was most often because the patient, again, was in early diffuse stage, and that meant that they were at higher risk for having renal crisis and not that pregnancy induced it. And so that all the old literature, which suggested that it was the pregnancy that induced the renal crisis, when you looked carefully at those patients, most of them were patients with early diffuse scleroderma. In general, renal crises can be a bad outcome, and the problem is in pregnancy is that the main drug that we use is one that is contraindicated. So ACE inhibitors are contraindicated because they have a toxicity in the babies, and so there's often a delay in treatment of renal crisis, and so in many of our patients, the moms did poorly, although we were able to salvage several of the babies. So in general, we do not feel that renal crisis is associated with pregnancy, but that it's the fact that it's associated with early diffuse disease. So as far as managements go, it's really important that early in the pregnancy and actually even before the pregnancy that you consult with your rheumatologist, you see a high-risk OB doctor. We do know that there is increased prematurity, so we have to really watch patients very closely and monitor them and deal with that high risk. We really discourage women with early diffuse disease to not get pregnant during the first 3 or 4 or 5 years, at least until their disease stabilizes, because there's so many different problems, including progression of skin, pulmonary fibrosis, and renal crisis. And so that's probably the main time we discourage women from becoming pregnant. You have to change the toxic medications so that many of our medications that we use for scleroderma, methotrexate, Celsep, mycophenolate, ACE inhibitors, are all toxic, so you can't change them. There is one immunosuppressive that can be used during pregnancy. It's been used through transplants and it's used through many pregnancies, azathioprine or Imuran. You can also use low-dose prednisone, but you really have to use sparing doses of nonsteroidals, the GI medicines, the medicines for Raynaud's calcium channel blockers. Fortunately, you don't really need them as much at that point, and we always encourage adding folic acid during that time. You have to manage the pregnancy as a high-risk pregnancy, and particularly follow the blood pressure in patients, and particularly those with early disease and those with SCL70 antibody, and look for prematurity. So if someone does develop new hypertension while they're pregnant, it's sometimes very challenging to separate whether it's preeclampsia, which is a complication of pregnancy, or whether it's renal crisis. But the important thing is you really cannot just be watched like they might do in a normal non-scleroderma pregnancy. You can't ignore it, because if it is renal crisis, not treating it could very easily mean both the loss of the mother and the baby. There are some blood tests that the doctors can do to try to separate preeclampsia from renal crisis. But the important thing is, if it is renal crisis, ACE inhibitors can be life-saving for the mother and the baby. And so even though this is a contraindicated medicine and there are fetal complications with this medicine, the most important thing is to control the blood pressure, because without controlling the blood pressure, both the baby will do poorly and the mother potentially will totally lose kidney function. The other issue is during delivery and caring, very particularly planning for the delivery. It's important to consider anesthesia, and using epidural anesthesia is better. There's changes in blood flow with general anesthesia and not having anesthesia. It's really important to do this. Special warming of the delivery room, using intravenous fluids that have warming the patients, using blankets, anything to keep the patient warm. Having venous access before delivery, and careful attention to the episiotomy, which is the incision that the surgeons use, just to make sure that things heal. The postpartum, there's really no risk for having hereditary scleroderma, and then there's such a thing as neonatal scleroderma, but it's not in scleroderma patients. And you need to carefully follow the patients to make sure that they don't develop other complications, development of the hypertension. You can't just assume it's going to resolve after delivery. So in conclusion, miscarriage and neonatal deaths are no different than controls. Prematurity is significantly increased in both limited and diffuse scleroderma patients. Patients should be managed as high risk, and although problems can be challenging, most patients can have a successful, healthy pregnancy. Thank you.
We'll answer questions at the end of the session. Our next speaker is Ramona Kanters. She was diagnosed with scleroderma at 32 years in Netherlands, and her personal fight with her disease has been courageous, wide-ranging, and successful. She is proactive now in helping others, creating awareness, and she is going to talk about enjoying your relationship.
Thank you for introducing me. Hello everyone, my name is Ramona Kanters. I'm 39 years old, happily married, and a mommy of an 11-year-old boy, Timon, and a 7-year-old girl, Flora. In 2005, 3 months after the birth of Flora, I was diagnosed with systemic sclerosis. In hindsight, I can say that I had many symptoms even before my pregnancy. Puffy fingers, joint pains, intense weariness, and dry nose, to name but a few. To battle this disease, I underwent chemotherapy, 12 intense sessions, but it wasn't enough. In 2012, I underwent a stem cell transplant that has thankfully been effective. During my stem cell transplantation, I made a deal with myself. I wanted to do everything in my power to help others who were battling with systemic sclerosis or other autoimmune illnesses. And so this is what I am started to doing right now. The company that I initiated is currently doing research to find out how patient care can be improved. By in-depth interviews and questionnaires about all different aspects of their treatment, we try to map and optimize patient health care. Today I would like to talk to you about one of these, namely the taboo that surrounds systemic sclerosis and sexuality. Our research found out that many patients experience pain during sexual activities and find it hard to talk about this. At the same time, physicians find it hard to address this subject with their patients and often are ill-informed. Many end up advising their patients just learn to live with it. Well, there are many things that can be done about it. During our interviews with these patients, it became clear to us that the subject of sexuality is both very emotional and heavily laden, and for some couples so heavy a burden to carry, causing a number of them to enter relationships. With the right information and support, this problem might have been overcome. This is just an example of the areas of improvement of healthcare surrounding systemic sclerosis. But now we are there. Dear physicians, my advice to you on this subject would be, listen to your patients. Don't send them away to continue struggling on their own. Point them in the right direction. Send them to an expert, for instance, a sexuologist or a psychologist. In any way, don't make people swim the sea on their own. Thank you.
Our next speaker is Gabriella Verzi. She's a FESCA member from the Italian National Organization, AILS, and lives in Sicily. She was diagnosed in childhood She has had varied experience of scleroderma treatment therapies, both in the UK and in Italy, including stem cell therapy. She's going to talk about developing sexual confidence.
Thank you very much for the introduction, and thank you, Annie and Pesca, for inviting me to speak about this very hard topic. I must say that I have struggled to do my presentation because I didn't even know where to begin. So I hope to be very good. Now, these I call the circles of love because for me they represent all the factors that makes patient to feel not comfortable with their partners and with sexuality. So intimacy, self-image, desire or feeling desired, depression, anxiety, joint pain and stiffness, and fear are all those factors that influence someone to feel uncomfortable. So how can scleroderma influence your relationship? We all know that sexuality is an obstacle and a taboo that undermines the sexual sphere, the couple's relationship, and the psychological well-being of an individual. Sexual dysfunction affects the pressing on the family's menage. Therefore, sexuality becomes a thermometer of the relationship, not only with the partner, but also with themselves. And as we said before, this aspect of health and well-being must be faced and deepened and cannot and should not be a taboo. As we all can imagine, the physical and emotional problems and difficulties in a married life that arise from stress related to the disease have a heavy impact on the sexual functioning of patients, contributing to a less active and fulfilling sex life. Sexual impact varies from person to person. Most patients complain, however, a decrease in sexual desire, a reduction in the frequency of intercourse, and an overall increase in sexual aversion and a decrease in sexual satisfaction. In men who suffer from this disease, vascular damage, stiffness of the skin are responsible for 80% of erectile dysfunction, decreased desire, and orgasm. The main manifestations of sexual disability in patients is the difficulty to take certain position for the limited motility of the hip or knee, joint pain, and fatigue during intercourse. In fact, the physical symptoms typical of this disease is the pain, the chronic fatigue, muscle and joint stiffness, and functional impairment. Therefore, chronic pain, mood disorders, and the profile of the disease, anticipatory of anxiety and drugs taken, trigger a mechanism that fades and can stop the desire. As we all know, scleroderma makes you lose also self-confidence. You feel less attractive and leads to a change in the emotional life, making it difficult for the couple. Many of you have never shared this with anyone and will not do so, mainly because you are convinced that there is no remedy. A crucial role is also the physical appearance that changes with time, thereby intensifying feelings and pain. A negative concept of your image drops your self-esteem, experiencing feelings of inadequacy in comparison to femininity. Physical appearance leads women to feel less attractive, resulting in difficulty in abandoning herself and or in taking initiatives. Closure to desire and pleasure. By repressing your desire or have lack of awareness of it makes intimacy difficult for the couple, and also fears and feeling of an inadequacy and loss of self-esteem sometimes blocks sexuality much more than the actual psychological difficulty. Actually becoming aware of your problems and sharing it may be the beginning of therapy. Rediscovering each other, thinking that sexuality is a pleasure and not a duty of the couple is a step in the right direction. In these cases, it is useful that partners try to have a more common approach in order to allow a gradual recovery of security. Another aspect is that the man reassures the woman that the physical signs of the disease are of little importance. The most important element is the dialogue, which aims to reveal slowly a new balance in the relationship. Living well sex is possible. However, if you move your attention, like I said, more on the relational and affective side rather than the sexual act itself, in the interest of the couple rather than the duty and performance. And to conclusion, these are my pictures with my boyfriend. And just to say, not forget to love yourself, which is, I think, is the most important thing. If you love yourself, your partner will love yourself. Thank you very much.
Our next speaker is Katerina Leite. She's had scleroderma for over 25 years, but despite this, she studied psychology at the University of Minho, is active professionally, and this year she has had a bouncing baby boy here in Portugal. She's going to talk about my new baby.
Thank you for the introduction, and thank you for the invitation to share my happiness. I have scleroderma for over 25 years, and now 4 months ago, I became a mother. And I will tell you a little about my story. I was born very healthy, and until scleroderma happened in my life when I was 12. It was a shock for everybody, and many doubts and fears were felt. What is scleroderma, and now what? And the answer was take the limitations of the disease and adapt what is necessary to have a quality of life is important. And remember that scleroderma is only a small part of our life. I apologize about my English, it's not good, but I study. When I was, I went to the university far from home. I traveled with friends. I was one of the founders of the Portuguese Association of Patients with Scleroderma. I got married. I have a very normal life. What helped? My doctor, my family, and my friends. All the support is very important and very necessary. So this year, we decided to get pregnant. I talked to my doctor, and she said that I have health conditions to get pregnant. But when we went to the obstetrician, I was told that I certainly would need fertility treatments to get pregnant. But when I went to medical tests to begin treatment, I was already pregnant. It was not a complicated pregnancy. This photo was taken the day my baby was born. I did not even have nausea. I worked until 7.5 months of pregnancy, 8 hours a day. And doctors choose to make my baby is born 1 month before the time because he was okay, but he's not gaining weight as expected. The baby was born by cesarean section, and he was born at 7 p.m. And the morning next day, I could walk on my foot, so I was okay. This is my first photo with my baby. He was born too little, so we had to stay a few days in the hospital. And this is photos of my little boy who is there. And I have a message for you. For the parents with the children with scleroderma, what can you expect? Everything. So your children can do anything. You can support your children, but they can do anything. And for all people with scleroderma, don't limit your dreams. I think is the most important message, because sometimes the dreams can become true. Thank you.
Thank you to all of our speakers. And the baby is our youngest speaker. He's over there in his pram. Yes, I think we can see him now. We do have time for a few questions before we go to lunch. We all have to go to lunch following a leader to make sure that we don't inadvertently look at the exhibition stands. And we have a seated lunch in the restaurant upstairs, but a buffet, so you'll choose from the buffet. Before we go, though, we do have time for a few questions. I'm going to hand over to the other chair and make sure that the mic moves.
Hi. Are there tips or therapies or solutions for vaginal discomfort and pain during intercourse?
Probably, again, I am personally not the most informed person, and I should ask advice to a gynecologist in the case. But I think there are a few local things, local cream or local things that can be good for vaginal pain. I have. I don't know if everywhere are the same. I think that cream that are used by the gynecologist for vaginal pain are useful in this case, also for patients with scleroderma.
I'll just like to add on that. Sometimes some patients find KY gel quite helpful, or mostly we just refer patients to the gynecologist, as Prof has just said.
I had something done to my vagina, and it helped. So maybe I want to tell people. I had lipofilling done. It's they took my own fat from my thighs by liposuction, and they injected it around my opening area from my vagina, and also in my face and my mouth, and it helped with flexibility. It really helped. It's not like it should be, but it helped because it wasn't possible to penetrate anymore, and now it is. So maybe it's helpful.
Thank you. Some patients want us to repeat it. The lady said she had some fat transfer into her vagina, which has helped to open up a bit, so it's not painful anymore. And that fat transfer has been done to her lips as well. Yes. Yes, fat transfer. It was from the fat. Where the fat is, basically. Any other question?
Okay, my question was if it was long term, so I'll give it to her.
The flexibility is indeed long term, although they say you have to do it twice, so it stays better. In my face, I did it because of aesthetical reasons, and those didn't stay as I wanted it to, but the flexibility of my mouth stayed, and the flexibility on my vagina also stayed, but it is Scleroderma is progressive, so it's also a bit, when your skin is thickening more and more and more, maybe you have to do it again. So, maybe.
I have a question for you. Sorry. Who did the fat transfer? Was it your rheumatologist, or you were referred to a plastic surgeon?
No, it was a plastic surgeon, yeah. Okay. But they were in communication with each other. Because at first, my rheumatologist didn't want me to do it because of the injections. It are little wounds, but it healed perfectly and no complications. But it is a bit of risk. So I don't want to tell it's the solution because. Yeah.
Okay, thank you.
Thank you. I am a rheumatologist and I am involved in some project about fat graft in Scleroderma patients. And we started with the perioral grafting, and now we progressed to the ulcer treatments by fat graft, autologous fat graft, and now we progress to the vagina treatment, as is your experience. And the rheumatologist can propose the treatment, but there is a surgeon, obviously, because a plastic surgeon, because for the face is a critical point, and we are not so prepared in this kind of surgery treatments. But I think that the results that we had are the same for Scleroderma patients and for normal patients, because you know that the fat graft is used for anti-aging therapy. And there is a reabsorption So it's true that it is a treatment that we can repeat, but there is, you have to know that there is a normal reabsorption of the fat. That is normal, and we cannot decide before what the result will be. So it's a sure, a safety treatment, and for the pain, the vaginal pain, the results are terrific because there is a natural, some natural endorphin, some natural molecules in the fat that can give a results, a good results on the pain. So I suggest that you can look for a plastic surgeon, but it's very important the collaboration between the rheumatologist that knows your disease and the surgeons that doesn't know the disease. So it's important to decide the treatment in patients that cannot have immunosuppressive treatment because the infection or the infective risk is higher. And so you can plan the treatment that is a safety treatment in some conditions, obviously.
Thank you. I will close the meeting by saying sexual problems are a challenge in scleroderma. However, communication is very important for the patient, to the rheumatologist, or to your doctor, as well as with your partners. So thank you.